Good evening, everyone, and welcome to our webinar discussion this evening. It's going to be in the form of a panel. Thank you for joining us. Most of you are joining us from South Africa, but there are others joining from other countries as well, and welcome to you too. Those who are South Africans and are health professionals registered with the HPCSA, if you have given us your registration number, we will sort out your CPD points in the next couple of days. You don't have to do anything other than to have registered, and we'll sort it out for you. Apart from that, thank you for joining us as we focus on some very disturbing recent developments and talk a bit about the impact and the implication of them. Certainly for myself, I find myself a little overwhelmed about what all of this might mean. And so we are joined by three people who come with slightly different perspectives, one with possibly a more international perspective, one with the perspective of what it's like on the ground, and then Mia with her perspective as a journalist. The way we're going to approach it is going to start off by giving each of the speakers 10 minutes or so, just to talk a little bit about the lay of the land and their understanding of what's going on and the implications. Then I'll probably put a few questions to the panelists myself, and then we'll open the opportunity for people to ask questions and to comment. For that, we're going to ask you to use the Q&A box, and you'll see the Q&A logo, the Q&A symbol at the bottom of your screen, and I'm going to ask, please, if you would then just type in your questions or comments into the Q&A. Don't use the chat for that. The Q&A is where we will look for your participation. With a very large number of people, such as we have this evening, it is helpful if we do it that way rather than allowing a lot of people to speak, which slows the process and gives fewer people opportunities. We may not be able to get to everybody's questions. We'll do the best that we can, but we also don't want to take up too much of people's time and run later than the time we've promised. So thank you once again for joining us. I'm going to introduce each speaker before they come on, and I'll also ask them that if there's anything further they want to say about themselves as an introduction, please to do so. I'll just keep it as short as possible so as not to spend too much time just on introductions. So Mitchell Warren is the Executive Director of AVAC. It's an advocacy organization that focuses on accelerating access to effective HIV prevention options and ensuring access to everyone who needs these options. Mitchell's also had significant experience in health promotion and other forms of healthcare through many years, and has worked in Africa and particularly in South Africa at one stage for 5 years. So has something also understanding of the context, which I think is very helpful for those of us who are from South Africa and others perhaps from the continent. So thank you very much, Mitchell, for joining us, and we look forward to what you have to share.
Great, Kevin, thank you, and thank you all for joining. It is truly a great pleasure to be in community and in conversation with all of you. But it's devastating why we're being brought together and the conversations we'll have together over the next hour or so. You know, as Kevin said, I actually began my career focused in South Africa and made my first trip there in the late 1980s. And I have thought a lot about that over the last couple of months, or the last month. I will tell you now, the last 4 weeks feel like a lifetime. And I'm sure that every one of you feels that way, whether you are an academic, an implementer, an advocate, a community member. All of us, all 400 of us are community members. It has been an exhausting 4 weeks. And I think that's quite intentional by what I will just very blatantly call an authoritarian and even fascist regime that's taken hold of the country that I am from, the United States, and where I currently live. But I thought a lot about my time in South Africa, and I was so glad, Kevin, to be invited by you, because my work began in the midst of apartheid, when I worked for an organization that was working to support Black South Africans to become health professionals, very much in response to and in the spirit of Steve Biko. And so to be called here in this moment under the auspices of the Steve Biko Center is so very important. Because as we all know, and I know a number of you on the line looking at the names, and it's great to see very dear old friends, young still, but longtime friends, that HIV has never been a health issue only. I can remember in the late 80s and early 90s that in the earliest meetings with Edwin Cameron and Zaki Ahmad in what was then the AIDS Consortium. I'm going back through memory lane a bit, apologies. In the early 90s, and setting up the AIDS Consortium, and eventually what became the most remarkable civil society movement, led by many of you and your comrades in South Africa at the Treatment Action Campaign. It was always with the recognition that HIV was not a health issue only. It was about community, it was about society, it was about sexuality, it was about drug use. It was most of all about human rights. That's what this has been about for 44 years. And what's amazing is, and we often talk, when America sneezes, the world catches pneumonia. And I am deeply sorry that my country has sneezed and caused something far more infectious than pneumonia, what has happened in the last 4 weeks. Because up until then, for now over 20 years, the President's Emergency Program for AIDS Relief, PEPFAR, along with the Global Fund to Fight AIDS, TB, and Malaria, for 20 years have been beacons of hope. They've been beacons of how science is generated and how communities drive policymakers and scientists and HIV doctors and anybody and everybody to do the right thing. And it's why South Africa now, after years of, and I remember those dark years in the late 90s, early 2000s, when it was about denialism and it was about denying people access to treatment. And together around the world, South Africans, Americans, and everybody came together to launch what is inarguably the best investment ever in global health and development. PEPFAR and the Global Fund have transformed not just the AIDS response, but have transformed health systems. You'll hear that from a local perspective from other panelists. And you all know that. And South Africa now home to the largest, not just the largest HIV treatment program, but South Africa is also home to the largest PrEP program. It's had the largest voluntary medical male circumcision program. When I moved there in the 90s, we began condom social marketing, and it had been the first country to introduce the female condom. Every research study in the world in HIV treatment prevention included South African investigators and was very often led by South African investigators. And again, you don't need me to tell you all that. You live it, you know it. And in 4 weeks, what's taken now 44 years to live and 20 years to develop through these programs in partnership with communities and governments on the continent, what took 20 years to build up has taken less than 4 weeks to dismantle. And I think we all know that it's much easier to break something down than it is to build something up. And it's not just about building up health systems and the number of health workers, and it's about the trust and confidence that we all have in systems. And we know over many years that it's hard to keep that trust. Certainly COVID challenged that, our trust in science, our trust in research, our trust in medicine. And yet we persevered. And now we have found in a couple of weeks the dismantling of that. And so maybe I'll give just a very quick sense of the chronology. So I think you all know 4 weeks ago, the inauguration took place with a dictatorial authoritarian leader in his second term. And we knew it was going to be hard. There was a document called Project 2025, which over the last couple of years was written by many of his former staff in his first administration. It told us, it telegraphed to us what they were wanting to do. It included talking about dismantling PEPFAR and ending global assistance. But no one thought they would do it with the speed and scale and inhumanity that have happened. So the inauguration was 4 weeks ago. Within a day, actually that very same day, that night, one of the very first executive orders by the president was to pause foreign assistance, which included PEPFAR. But it's not just about HIV. It was about HIV and TB and polio and vaccination and contraception and humanitarian assistance and democracy support. I can remember in the election in '94, the National Democratic Institute was there to monitor the first free and fair election in South Africa that many of you participated in. That was funded by USAID. The NDI admission to monitor elections, all of that is part of foreign assistance. And I would argue, and there's a huge amount of evidence, that all of that makes America stronger, safer, and more prosperous, and it makes the world stronger, safer, and more prosperous. But the executive order said, we're stopping. We're quote unquote pausing for 90 days. But as you know, small nonprofits can't really get by for 90 days being told not to work. So the mass layoffs in South Africa and around the world, the stopping of drug supply. You know, in the old days, we had stock outs where there wasn't enough drug in clinics. All of a sudden, we had stock in clinics, but we had staff out. So we couldn't even deliver treatment and PrEP. That was now 4 weeks ago. And then a week later, they issued a very ambiguous statement that there would be waivers that would allow foreign assistance on a case-by-case basis. None of us who work in the PEPFAR space have seen the waivers actually mean people can get back into treatment and other programming. And very importantly, one of the things the waiver did most ridiculously was to say that even under waivers that might be granted, that PrEP and circumcision and condoms would not be allowed, that US assistance and even the drugs that were already purchased couldn't even be used. It's absurd because we know those are life-saving products just as much as treatment is life-saving. They prevent infection. And so those are not going to be continued. But still, 3 weeks later, we've seen hardly any movement. There is a bit of confusion. PEPFAR is funded through primarily USAID and the US Centers for Disease Control and Prevention, CDC. The CDC funding is a little bit different and theoretically is allowed to restart, although I know that, and I'll leave my South African colleagues to comment, we aren't seeing things really turn back on. And the one thing I always say, these programs don't have on and off switches. You can't just turn it off one day and turn it on the next and think everything's going to be fine. So we've now waited almost 3.5 weeks. The one other thing I'll say, at AVAC, we work in HIV prevention and advocacy. We do receive PEPFAR funding, and we actually are the lead plaintiff on one of 2 lawsuits brought against the government last week. They were filed last Monday and Tuesday, the 2 different cases. On Thursday, within 48 hours of the second case, the judge found in our favor and granted what's called in America a temporary restraining order, telling the government the pause was not legal and they had to start funding again. And that was last Thursday night late. Late last night, 4 days later, what you found was the government's response, which basically was a big, I want to be careful with my language and not offend anybody. It was a big, we don't care what the plaintiffs say, and we don't care what the judges say. And basically that document, which was posted late last night, says everything we're doing is within our legal rights. We are fighting that. We're filing a further motion today to say the court cannot be ignored. So this is not just about HIV. This is not about healthcare. This is about legal rights. This is about human rights. And this is why we have a huge amount of work to do. And I'll just say one other thing. This is not going to stop overnight in America, and it's going to have implications everywhere. And we need to document that, and we need to make sure that every American and every global citizen recognizes what havoc this is wreaking, the chaos that's ensued, and the political, economic, and medical damage that this is causing in very real time. So I've thrown a lot at you. It's my morning, so apologies if I went a little long and over caffeinated, but I just really want to thank you all for being here and happy to turn it over to my friends and colleagues and have a conversation.
Thanks so much, Mitro. We'll move straight on to Dr. Ntombi Fikile Mchali, who's the CEO of Shout It Out Now, who many of you will know. An organization that's focused on providing sexual and reproductive health and rights services to youth in Gauteng and Northwest provinces, and so much more. Perhaps you'd like to tell us a bit more about what you do as well. But thank you again for joining us to talk a bit about your experience on the ground. Thank you.
Thanks, Prof. Good evening and good morning to you, Mitchell, and good evening to everyone. I'm here. I don't have anything to add to my bio other than the fact that I'm also coming here representing the rest of the implementing partners in South Africa as well as the supporting partners. I think most of us would be aware that, and I'm also mindful that I'm speaking on camera today, while most of us are reluctant to do so because of the volatile environment and the uncertainty that we are facing at these times. So it's either I'm very courageous or madly stupid, but I am emboldened by the group of implementing partners that I represent, and I hope to represent their experiences, insights beyond just Shah's experience. So having a collective implementer's voice. So I want to start just by talking about where we are with the South African HIV response, just acknowledging the strides that we've made, that it's been combined in collective efforts between the South African government, which contributes 76% of the investment. We know this because in the media we've been hearing some of these things. But the rest of the investment comes from donors such as Global Fund as well as PEPFAR. One of those major donors is PEPFAR, coming in at 17%, like Mitchell has said. But what does that 17% do? We know just that we're supporting care and treatment programs, so testing, linking patients to care, to art intervention, making sure that we are testing them for TB, retention in care, ensuring that they are virally suppressed, so doing viral loads, making sure that we are following up those results. We also know that it provides mental health support to your support, because we know there are many challenges that come with, and we know that also mental health plays a role in the retention efforts when we talk about adherence to treatment, et cetera, et cetera. And also, we need to also talk about the community-based prevention interventions that Mitchell also has touched on. So the PrEP, the VMMC, voluntary male medical circumcision, the condoms, et cetera, et cetera. And those are largely delivered through the implementing partners. And what the impact have we seen over the years is that our life expectancy based on this investment has improved from 54 years in 2006 to 65 years in 2017. So we know more people are leading productive lives for longer. They're becoming economically active. They're remaining economically active, and that grows the economy. So the executive orders, as we've already started to, and I think most of us are aware, they're impacting this PEPFAR funding. So this has created unexpected gaps, absolute chaos, and disruption in the services. I'm going to quote some figures, and I'm very mindful that it includes other countries, and so we need to read them in context in terms of the South African picture, because we do have a large population in terms of the epidemic size. So we know that the numbers would look a little bit bigger for South Africa. But we know that from a patient outcomes point of view, it's people that will be impacted. It's estimated over 100,000 lives, with just 1,000 of those being children. We know that 5.3 million people are actually on treatment. I also want to touch on an equally important part, which is the livelihoods and the workforce. More than 13,000 people are employed by PEPFAR implementing partners. This includes doctors, it includes nurses, lab support. I've spoken about the viral loads, data capturers, community health care workers. And these are in the communities. And so you might, most people might know that with the PEPFAR investment, it's only in the 27 districts out of the 52 districts in South Africa. But we know why those particular districts were chosen. It's because they are high burden districts. And if you're all looking at the Pareto principles, you know you want to try and get to the 80% with your efforts, without obviously neglecting the 20, but you want to be able to say, we're going to pull the levers on on where we can make the difference and we can see the impact. So I just want to also just give an update, just from an implementer point of view. We know that some partners, including Sheltered Now, have received exemptions and return to work orders owing to the temporary restraining order. However, other partners have not. And I want to quickly reference key populations, prevention and community-based interventions that have been left out. As a clinician, I struggle with that from an ethical point of view, because prevention efforts like PrEP, condoms, circumcisions, we know that that is ensuring that we're not having new infections. So while the focus is on life-saving treatment and care, we also should not be neglecting the prevention side, because it is as important. The statistics that I can quote is that every day we have over 600 new infections. So that is telling us we've got a problem, and we've got to be able to focus some of our attention to the prevention parts. Mitchell, you've spoken about the dismantling being easier than the building. We are experiencing this firsthand for patients who we had to redirect just less than 2 weeks ago, to find them alternatives to the South African government facilities, other delivery platforms, which already was chaotic at the time we were doing. Now we have to bring them back or find a way of ensuring that they are continuing on treatment. From a staffing side and people, we've had to put people, temporarily lay them off, give them options on retrenchment and basically immediate termination of contracts. So having to now reverse some of those things is a bit of a challenge. And you can imagine the emotional toll it has taken on our people, being told that you are out of jobs, and then we have to resume, and we have to actually resume as quickly as possible. But I also think, most importantly, the other impact is on our organizations that are funded by PEPFAR, and how fickle this environment is, and that we need to be thinking around what else we need to be doing to ensure that we are safeguarding the HIV response. So we are engaging with the South African government through SANAC for immediate solutions to close these gaps, and appealing to corporates, philanthropists to lend a hand to this response as good corporate citizens. We now have some concerns with the budget speech not being proceeding today, because our hope would have been that some of those that guidance, some of those engagement, and some of those some of the reassurance will come from that budget speech today. But also we need to fast track then our sustainability as a country, because we have to agree that we were caught napping. We knew that PEPFAR or these global support, it's not here indefinitely. So we believe that now is actually the time for us as government in South Africa, and civil society, private sector, and other global partners to step up, mobilize resources, and drive innovative solutions that are sustainable to be able to safeguard the HIV response. Thanks.
Thanks, Ntombi, and thank you for being prepared to speak to us and be on camera. I'm quite sure that you've had to dig a bit deep because it's certainly brave given our context. But I think it is important also that we do bring some of these issues to the surface and talk about them. We'll come back to your last point, I think, when we come to discussion. Thanks very much. I'm going to turn now to Mia, and most of us will know Mia from the work that she does with Becky Cisa, with the Centre, which looks at health journalism and specializes in narrative solutions journalism, focusing on health and social justice issues across Africa. I'm deeply grateful to Mia, not only just for being here and sharing with us today, but also for helping to put together a meaningful event today. It's because of her that we have our other two panelists participating and adding to our experience. So thank you so much, Mia. And yeah, we look forward to hearing your perspective.
Thanks very much, Kevin. I'm going to try and be short because I'm, of course, just a journalist, but I can't do my job during a time like this without people like Mitchell and Ntombifikile. If I don't have them to trust me, to tell me things, there will be no stories. So for those of you who don't know Bekisisa, we are a donor-funded media organization, so we don't make a profit. We're very lucky that we can operate during times like this. And we don't really file, breaking news stories. But during a time like this, we do start to do it. And we file a story on our website, and then it gets republished by mainstream partners. So when we file a story, it gets published 7 times because we file with a Daily Maverick, News 24, all of those publications. So I thought, as a journalist, just when Mitchell so eloquently mentioned the HIV denialism during the late 90s and early 2000s. It feels a little bit like that to me as a journalist, this period, because I was a very young journalist, but a health reporter then. And if you were a health reporter during that time, you were an HIV reporter. It's all you did. You just ran after, reported on what the president and health minister said, and then you explained why it was wrong. And I feel a little bit like a Trump reporter right now because of so many things to keep track of. Now, why it reminds me of it is because of the downright denialism of science. For instance, Mitchell mentioned the supporting of treatment for waivers, but not prevention. It just makes no sense. And it has the same consequences, or it will have the same consequences as what our country had, with hundreds of thousands of people being denied preventive treatment and getting infected with something, or deaths that we shouldn't have seen. And I think it's gonna get worse with a health minister like RFK Jr. in the United States. It's no longer just about HIV, it's about vaccines that's gonna be denied. And for a journalist, that becomes very hard because it's mainly a political issue. But if you want to report accurately and insightfully on these issues, on Donald Trump's executive orders, then you need to understand far more than politics. You need to understand, how government policies work, or how funding agencies work, or how organizations like the World Health Organization works. You need to understand that they can only buy treatment when they have enough money to approve that treatment or to do pre-qualifications. So to understand what Donald Trump's decisions would mean for not giving money to the World Health Organization. So you need a bit of an institutional memory, and that is where it becomes hard, where something is such a political issue, but there's so many other inside issues that you need to understand. And, I think the difference between the HIV denialism period and now the Trump period is that his destruction of foreign aid and global health happens at a significantly faster pace than what we saw during HIV denialism. Firstly, because I don't think even Manto Shabalalam Samang could make false statements at the pace of Donald Trump. And during that time of HIV denialism, there wasn't social media that we have now. And on that level, it reminds me a little bit more of COVID, because the executive orders happen more or less at the same speed that preprint studies were released. And now we also, as journalists, need to keep track of court cases. I don't understand the US court system, so I need to ask people like Mitchell all the time, what does a court order mean? Because the documents are hard for me to follow. So I thought what I would do is to tell you about 3 things that I've learned as a reporter, and then leave it there during this time. Just before I do that, one of the challenges that I've experienced is, during COVID, it was so clear what you were going to do. You're going to put a story on a website, and then you were going to go to social media, and Twitter was the thing, or X today, where you would do a thread on something and it would get so much traction. Now, that social media platforms are fragmented because X has a new owner, Elon Musk. It's extremely hostile to news. It doesn't get traction. Now there's Blue Sky, but it's, Blue Sky has far more people in Western countries than in South Africa. It's only starting to pick up now. So it's so hard to decide where to direct your resources to because there are now so many fragmented channels that you need to distribute information on. And, it's all time consuming and you just can't do all of them. So the 3 things that I've learned is trust. Trust is probably the most important thing for a journalist during these times because there are almost no official statements because everyone is too scared to talk. So almost every story, I've done 8 stories so far, almost every single one of those stories have happened because people like many of you who are, listening or tuning into this webinar have given me documents that I could work with and were very, very generous with trust. And if I don't honor that trust, then you're not going to talk to me again. So I have found that the currency of that trust is consistency. To every single time try to do it right and to not break someone's trust. But in order to get it right, I need people like Mitchell and Tobifikili at 11 at night and say, they may not even be in the story, to say, check if this is right, because sometimes I don't have it right. And I'm encouraging many of you who are an audience here to give that to journalists that you trust. Because if I didn't have that trust, if people were not so generous with their trust, I don't think a single one of those stories would have happened. When the court ordered the US government to restart CDC projects, I knew about it because one of the implementing partners contacted me and said, yeah, look at this letter that we got. And because of that, it enables a journalist like me to bring that information out to many and to bring it together, basically, for people like you who may only have access to fragments of it, not that I have access to everything. And secondly, I have learned that, in South Africa, a lot of the coverage has centered around in the health field, around the impact on HIV. But it's about so much more than HIV. It's about, broader health issues. We're going to see a drop in the uptake of vaccines because of all the policies and the statements that come out of the United States. We're going to see more climate denialism because we have, a president who doesn't believe in climate change, and we have an energy minister, or that, that would likely be that person, and who just don't have good policies about climate change. And he's interfering with other countries. He's interfered with my country, just downright spreading misinformation about who's oppressed and who isn't. I saw this morning that Trump has filed, his media company filed a court case to help President Bolsonaro in Brazil, to try and prevent his arrest by arguing that there's no free speech and right-wing people can't say what they want to say. So we're going to see so many more implications, but in my field, media organizations are closing down. So one of the world's largest media development organizations, Internews, had to let 80% of their people go overnight, basically. And if we don't have enough media and enough media training in the world, people like Trump start to flourish because there are not enough people to check and to fact check and to spread the right information. So we in the media are going to have to do more with less. And if we think we've done our story by filing it on our website, that is done, we're living in a dream world. We're going to have to fight the information on social media. And a journalist like me almost like don't have the right to not help radio and TV organizations because they generally can't afford specialist reporters. So just in the past 3 weeks, I've done 17 media interviews in addition to the stories that I had to write for Bekisisa. I can't say no because, and it doesn't mean that I take the place of experts. It means that I do those gaps that are appropriate for a journalist to take the information that people like Mitchell and Ntombifikile give me and to break it down in a way that people can understand it. The last thing is I've learned that trolls are the same people who trolled us during COVID. The anti-vaxxers are the same people who are the Trump supporters, who are anti-abortion people, who are climate denialists and anti-science people. And my biggest lesson during COVID was mute, mute, mute. Just don't see what they do. Thank you, Kevin.
Thanks, Mia. Yeah, I hear you about the trolls. Okay, so just in response to what you've all said, I think people who aren't directly involved, looking in on from the outside, in a sense, often feel a kind of sense of hopelessness. And I think it's because often people feel compelled to do something, to respond in some kind of way, but have no idea how to. So do you think there is anything that people can actually do that would be of some kind of help, some kind of comfort, anything? Is speaking out or organizing or trying to arrange some kind of, solidarity, something, creating pressure groups on social media, any of those things? Is there anything that people can do that could be helpful? Or is that kind of thing at the moment anyway, while everything's still so precarious, is that sort of thing more likely to do harm than good? I'm always worried about kind of do-goodism that actually has the opposite effect of what's intended. Would any of you like to respond to that?
I'm happy to start, Kevin. It's a great question, and I'd say a couple of things really, really quickly. One, they want, and when I say they, I mean the leadership in this country right now. They want us to be confused, they want us to be exhausted, and they want us to be paralyzed. And I can tell you, I am all three of those things and a lot more. But when we are, they win. And so we can't, as hard as this is, and it's not just for in America, I think for everybody, this is one of the hardest things I've experienced. And we can't let them win. Now, having said that, we have to get really strategic, and I think it reminds me a lot of in the U.S. it was act up, act up, fight back. In South Africa, attack. But those organizations didn't just yell and scream. They were really smart and strategic in what they did. And I think for the first couple of weeks after the inauguration, it was panic stations, and that's understandable. There are crises all over. We need to address them, and including with legal action and in the South African government stepping in. We need to crisis manage. I think the most important thing is that people need to collectively plan for a future, and it's going to be different. I don't think, and I'm sad to have to say this, I am no longer fighting for things to go back to January 19th. PEPFAR is not going to be the same. USAID is not going to be the same, as Mia describes. I don't think any institution in the United States is going to be the same, and that has the knock-on effects. But we have to then, I use the analogy, we keep plugging every hole in the dike, and the holes are coming more and more every day, and they're getting bigger and bigger, and we need to plug the urgent ones, particularly keeping people on life-saving treatment and prevention. But we also, health workers, advocates, policymakers, need to go a little upstream and build an entirely new dam. It's going to take a new type of partnership. And I saw there's a great question in the Zoom about what does this mean for future aid support, lowercase aid and uppercase USAID. I don't think it's going to disappear completely, but it's going to be renegotiated, reevaluated. And already South Africa is the best example, a country that is, as you know, is driving the lion's share of the funding for the AIDS response, but relied on the US for some pieces. We need to accelerate that everywhere. I don't think foreign assistance will end. I hope it doesn't, because it's needed. But I think we need to think about an entirely new architecture for this ecosystem. And so people can be engaged in that. And that can be very strategic and operational. It can also be in protest. And I do want to just say, because Sharon is an old friend from way back, her question, 99% of Americans didn't even know what USAID was. I've worked with USAID for 30 years. My mother didn't know it really until I started working with USAID funding. No one knows what USAID is in America. More South Africans know what USAID is and what PEPFAR is than Americans. So we do have a huge educational piece. Most Americans think half the federal money in their taxes goes to foreign assistance, to people outside of the country. That's absurd. It's less than 1% of the entire federal budget. So there's a huge education we have to do in the US broadly, but we also gonna have to get really strategic. Talking amongst ourselves, I mean, and I'm loving this and I love being with all of you, but our advocacy needs to be directed to people who, some of the biggest supporters of PEPFAR are right-wing conservative Republicans who are now abandoning what they said for 20 years, including Marco Rubio as a senator was one of PEPFAR's biggest supporters. Now you think, as the Secretary of State, he thinks that PEPFAR has been 20 years of mismanagement. It's absurd. He's a liar. He's wrong. We need to remind him that his whole career in the Senate with PEPFAR support is the truth. And so we can't just yell at him. We have to work with him, his staff, to make sure we bring people on the conservative side back into recognizing the value of this. So it's going to be a really strategic campaign over the next year, 2 years, 4 years.
Thanks, Mitchell. Komikine?
Yeah, if I may offer some insights, and I'm coming after Mitchell, so Mitchell covers some of the things that I need to say. Next time I'll come before you, Mitchell. I think there's definitely, so the first thing is, for us in South Africa, HIV is still a big problem. We've made significant strides in the response. We've come from the dark days of funerals every weekend, multiple funerals in the weekend. And that has been because of the collective efforts and the response and the investment that has been made over this time. And we really want to be appreciative of it. But we also need to start thinking about a new way. What does that look like? A new way for South Africa as a government. We are pouring so much resources in this. How do we ensure that these resources are able to cover all the aspects that PEPFAR or other global health donors are able to cover at this point, really moving towards that sustainability that we've all been talking about and has now been fast-tracked for us because, because of the external political issues. So we need to really get together around the table, figuring that out, really working through SANAC as that vehicle between government, civil society, as well as the private sector, because private sector also needs to come come to the party, I think. But also, I think the second part is around, as implementing partners that are funded predominantly by global donors, PEPFAR included. What is the new way? What does that look like? We can no longer afford to exist in the way that we've existed before. It probably was comfortable, but now we need to be thinking about it slightly different. I think also what we need to do is still continue to educate the public around that HIV is a problem. Working with on the prevention side, for example, I work with young people. Young people do not think HIV is a huge problem in South Africa, or even for them, it ranks as number 4. They're worried about pregnancy, they're worried about contraceptives and other issues, even bread and butter issues like food. Where's my food going to be coming from? HIV isn't part of them, isn't part of that. So we still need to be raising the education levels and awareness around that HIV is still a problem. We still need to invest resources in the prevention, because we know that adolescent girls and young women, key populations like men who have sex with men, transgender people, as well as people who inject drugs, they're still driving the new incidents or new infections. So we need to be still talking about it and advocating in that way. Thank you.
Kevin, I wanted to make 3 points about this. The one is, I agree with Ntombifikile that a crisis is also an opportunity to sometimes speed processes up and get things right. And one, good thing that has happened in South Africa is we saw the health department announcing that we're going to move to 6-month dispensation for ARVs. And, that has been in the making forever, and they were very slow with it. And now they're going to try and see who can get get 6 months of ARVs at a time so that the clinics aren't overburdened. So that's one good thing that was an opportunity to speed up a process. The other thing is actually something that Mitchell taught me. We've got the tools. In HIV, it wasn't just in South Africa that we won the battle. It was an equally hard battle in the United States. And in both countries, activists, the community, in other words, scientists and policymakers came together and they used the legal system. And if you bring those components together and you are strategic, you can win a fight like this. It doesn't mean it's going to look the same, like Mitchell said. USAID is not going to look the same, but you're gonna be able to build to conquer the misinformation. The other thing is I saw questions here on the Q&A session, and I know I can't do all of them, but there's one special question because it's from Liz Gold, who lost a job. She is one of the victims of this whole thing. She was my former boss, actually, in a former life. And she asked for the thousands of us who were recently terminated from international NGOs funded largely by USAID. How can we best help the media to tell these critical stories about the repercussions of all this nonsense? And Liz, my answer is tell us your stories. Trust us to tell us your stories. You don't have to trust all media. You can trust the people you've worked with or write for us. I would love a piece like that of someone, what's been the impact on their lives. We'll help you to edit it. We'll help you to get it out. And we'll also be prepared to not put your name to it if it's going to, have too many repercussions.
Thanks, Mia. And that's been actually quite hopeful, that part of our discussion. And so I think we should move away from my questions, because there are lots of people on this call, and I'd like to give them some opportunity to put their questions as well. Just a reminder, if you have any questions, please do put them in the Q&A box, so that we can keep track of what we've been able to respond to and what we haven't. And then also, if you can also see some people have put in sort of almost personal messages to some people, some of the speakers. Please do that as well. I'm quite happy to share the Q&A with our panelists afterward. So that's just one way of communicating with them if you would like to. So I'm going to go on to have a look at one of the questions that has been asked. So I'm just trying to look for one. So there's a question directed to you, Mia. All politics aside, is it possible that Dr. Nicholas Klitzman, the NHI incubator, might be able to help us here? The question disappeared.
Yes, from Amanda, right? Amanda, I've actually just answered you. I agree with you that, there's no more important time for universal access to healthcare than now, because also we're going to become less reliant on donor funding. I don't have clear answers for you whether the incubator is going to help, whether Nicholas Crisp, I can ask him. But I think someone like Mitchell and Toby Fikele are probably going to have better answers than me. Yes.
Thank you. There's a question from an anonymous attendee. Why is it that the implementing partners did not properly inform the department when they stopped working? Didn't know anything about that, but maybe someone does. What psychological support was provided for the people who lost their jobs, seeing that the majority of them were low-earning category? I'm not sure if anyone is able to answer that question, but if anyone is, please go ahead.
Yeah. Sorry, Prof. I'm happy to answer that question, not because I have a good response, but just to highlight that as implementing partners, we also, because of such a chaotic manner that this was done, and I don't know if people can appreciate that we were working the one day, and at about 1700 on the same day, we were told that we need to stop working and with immediate effect. And what that meant also is, and what also came in that directive was anything that you do beyond today will be unfunded. So basically you are on your own. And if you know how implementing partners and most of the NGOs work, how they work is that we are project-based. So there's no way, we do not keep reserves. We're not sitting on lots of money that we can be able to continue. So when that directive came to say you need to stop working because you will not be funded, we had to stop working and we had to do it immediately. That created chaos, as you can imagine, as I've already highlighted. We had to find alternatives for our patients or clients. We had to figure out what we are doing with our staff. What does that mean? Are we laying them off? Are we retrenching them? All of those conversations, and it speaks to the mental health support that, but it was also an information vacuum. I must just also talk about that. We couldn't engage with any of our funding agencies. I know some of the colleagues actually still can't engage directly with their funding agencies. At least some of us are able to do so now. So for at least a week and a half, there was no way where we could even ask questions. What does this actually mean? Can we do it in a different way, et cetera, et cetera. So we know that there was that gap. And we do apologize because we work with the government stakeholders and they are very important stakeholders and we work hand in hand. So some of the communications was very delayed. In terms of the staff, in some of the organizations, we definitely have what we call employee assistance programs that we were able to channel them to. I'm speaking on behalf of most of the organizations, but that is one of the things that we were doing. And I saw a question around what is it that we've learned from this crisis, or what we are learning here? We know that I think we stand at a pivotal moment in global health, as indicated. The implications of these PEPFAR, USG funding reductions cannot be ignored. And they threaten to erode the gains that we've made over the decades. But we don't have to be passive, and we cannot afford to be passive during this crisis. It's now time for us to really just come together as a country, find sustainable solutions. And this is a defining moment. So our collective response will determine whether we sustain these gains or allow setbacks to cost lives. And those lives are my mother, my brother, anybody, and our sisters, especially for us in our context. And the world is watching. So we need to rise to the occasion.
Thank you, Tombekile. There are a few questions that I think kind of go back to a comment that you made, and that was sort of seeing this as also a kind of a call to do things differently in the future. And so some of the questions are kind of focusing on our reliance on aid and on support from outside. And questions about whether or not we can use our own resources. Kafiso, for instance, says as South Africa we need to pull our resources together. PEPFAR is US money. Perhaps there are lessons to be learned for sustainability's sake. Let's use our own money. And I think quite a number of questions that touch on similar themes. What are the lessons that we should be learning?
Maybe I'll just jump in, and it relates to a bunch of, and these questions are fantastic. And it relates actually to a question Kate Hankins asked: what does it mean to go upstream and build it? How do we do it? We need to be thinking about building, and it is about NHI as well. It's building a system and structures that are not tied to any single funding mechanism. I mean, let's face it, no government funding is by definition guaranteed sustainable. Even if South Africa began to do everything today, and we don't need PEPFAR at all in South Africa, something could happen tomorrow in South Africa where you can't fund it either. So the two most important words to me are sustainability and resilience. And that's about building something different. And I think, and I've never lived through, thank God, an earthquake, but I know when buildings collapse in an earthquake, they get rebuilt and people build them differently. So I think we need to take this opportunity to build something different. And I do think in South Africa, of all the countries that receive PEPFAR support, is best placed because it's funding the lion's share of its own. I think the South African government and the community need to say, here's what we want and need. And here's what we need from different partners. And someone asked a great question. What about industry and particularly pharmaceutical companies? Let's face it, the innovator companies of pharmaceutical drugs, as well as the generic manufacturers, have the most to lose and the most to gain. So we need to work with them. We can't, governments aren't going to buy their drugs anymore if there's no money for it. So we need to be working with them directly. Often that went through PEPFAR. Obviously, South Africa is different because you procure most of your own drugs. But I think just in a very micro issue, we have this opportunity right now with lenacapavir, the most incredible South African studied product in injectable PrEP. Every 6 months, no infections seen in a trial took place amongst young women in South Africa. That's Gilead Sciences' product. If South Africa doesn't roll lenacapavir out, and it's going to get approved later this year, and it will go, and WHO is going to be giving guidance. The South African government's already been involved. South Africa, if you all are not the market for lenacapavir for PrEP, there is no market for lenacapavir for PrEP in the world. South Africa is the driver. So the conversation needs to be at the highest level, especially now that you're leading the G20, with the CEO of Gilead Sciences. You don't need PEPFAR. You need to say, if the government and the community says we want PrEP, let's figure out what that looks like and let's build it. And someone asked a question about Global Fund. Global Fund, and I know leadership of Global Fund was in the country just this week as they launch a replenishment co-hosted by South Africa and the United Kingdom. Don't be reliant on anybody. This is about self-reliance and being able to design something in partnership. We would hope that partners are good partners. And if you're going to leave with an exit strategy. That clearly is not, the US government has shown to be a really terrible partner. But build the partnerships that you want and hold people to account, but also know that you're building something that, that has to be built in to systems and structures that are sustainable, that don't rise and fall with political insanity.
Kevin, when I asked our acting Director General for HIV last night, actually, what is the biggest lesson that he's learned? His biggest lesson was when you take donor funding, take it on your own terms, more than the donor's terms, which I think is a very hard thing to negotiate because you're not always going on an equal on an equal level, but I think it is important. And I rely on aid. My organization is donor funded. And I think sometimes it's easy to say become sustainable, but it's harder to do it. But I, as a journalist who's reported on HIV for a very long time, think, as Mitchell said, we're in the best position of all African countries to use this as an opportunity to speed up becoming less dependent on donors in the field of HIV, because we don't rely for a large part of our budget on the support. But one of the positive things that have happened is, if you say do things differently, also look at local donors. And that has been quite an issue for a long time. But, as a result of just media stories, I've had a large local commercial fund, as I say, foundation, the CSI arm of a large bank, contacting me and said, who can we support? We want to provide bridging funding. And I don't think they would have invested in HIV necessarily if it wasn't for this crisis. They invested in other stuff. So this is a time where we can speed up those sort of things. I do think so. With COVID, we learned to do webinars. I know it sounds like a stupid example, but it became like a very common thing to do. In the media world, I normally get official statements. That is the most reliable information. I do things differently now. I get almost always anonymous statements because that's how you do it during a crisis. We can all learn from how to do things differently during a crisis. I hope I don't sound too positive because it's a horrible situation, right? It's not just positive stuff, but I do think crises do present opportunities to speed things up.
I think I completely, Prof. I completely agree with Mia here. This is an opportunity for us to pivot in a new direction, and it would be remiss of us to miss this opportunity to think things differently, to we've got what it takes. I think not just from a resource point of view, I think we still can galvanize and mobilize additional resources, particularly in the immediate term, but really need to come together and collectively, for that investment. However, we've got experts in South Africa, we've got advocates. Mitchell has touched on a great point. The PrEP, the lenacapavir trials, most of them were done in the continent, and South Africa being one of them. So we are subjects of and our participants for trials, but sometimes we're not getting access to those medications. So we really have a bigger role to be playing as well on the advocacy, and also we're going to be buying this as a government. We need to be thinking around how do we ensure that this benefits our people, and really this is an opportunity for us, and we shouldn't miss it. Thank you.
Thank you. In several of the responses and questions, there've been suggestions about ways in which alternatives can be found. For instance, relying rather on BRICS countries, talking about relying on companies in South Africa and the corporate world here. I'm wondering whether there's any place also for kind of response from just the people of the country. Is there place for sort of crowdfunding? Is there place for people, just individually making donations? Something in which ordinary people start saying, "Hey, we're not going to put up with this kind of treatment, and if we'll dig into our own pockets." Is there scope for that?
I'll put in a shameless plug for my co-panelists.
I'll take that for now. Can I start? Oh,
sure. No, I was going to make a shameless plug. People should give to Shout It Now, and organizations like it, but I'll let you answer. I didn't want you to have to say
That's
it.
fine. That's fine. And I think what we'll do, Prof, is also share the details, because we are working with the different implementing partners, and we wanted to do this in collaboration with the South African government using the same solidarity mechanism that we've done for COVID. So we're still in conversations around that, but definitely we would definitely want people to say, this is a crisis and it's a crisis in our country. How do we get involved and be able to give them a platform? And we'll share some of the details as well so that people can know how to reach out to us. Azil, I'm getting permission for me to share your details here so people can be able to reach us. Thank you.
Thank you so much. We still have quite a few questions. We're definitely not going to get through all of them, and I apologize for that, but I certainly will make them available to our presenters, and perhaps some of you might want to reach out to them in various ways, and please do that. But is it okay if we spend another few minutes trying to go through a few more questions? We normally try to finish these things in an hour, and anyone who needs to leave, please do. Thank you for joining us. But for those who do still have some more time while we have this opportunity, which is quite unique, perhaps we can consider some of the other questions as well. And I'm trying to find something. Did anyone of you speakers find a question you found particularly interesting?
One in particular. Oh, go ahead, Mia.
You go, Mitchell.
Well, one of the things that I've been really struck by is, let's be honest, no program is perfect. And the original pause in the president's executive order was to do a 90-day review. And if we thought they were honest, which they're not, every program should be constantly monitored and reviewed. So I would say a couple of people asked about efficiencies and every project can be improved. So I think we should use this as the opportunity to look at how we do things more efficiently. We've created systems based on the funding that was available in South Africa and everywhere else. And I think to this, one of the last questions that came in about the private practitioners, there have been efforts to bring the private sector into provision of treatment and PrEP. It's been hard. It's hard to do sometimes. There are policy barriers. There's funding barriers. This is the moment. Let's do it. Let's not worry about the PEPFAR requirement. I mean, PEPFAR, a lot of the PEPFAR expense does sit in administrative bureaucracy. So if we build back, let's do what President Biden said, build back better, make it more efficient. lean into the private sector, do things without ridiculous reporting requirements that might overburden systems and create more paperwork. Let's interrogate this. Let's not just restart programs. Let's build the best programs based on what we know. I think, and I don't know if Francois on, Francois Venter is taught me so much about, and his whole team at Essentia, about the private sector and the role of pharmacies. And it's been sluggish because of policy barriers. Let's say that's the way forward, because we're not going to see massive public programs funded by PEPFAR. So that's just one example that we need to get smarter and more strategic in all that we do. And again, to Mia's point, building it on our terms, not on bureaucratic terms, make sure we're designing the right things. If there's a piece of data to be collected that's going to really improve our program, and that's what PEPFAR has done so well for 20 years, let's do it. But if there's something that might have just been a bureaucratic piece of the puzzle, let's not include that in a new puzzle, so to speak. So I think that it is really opportune to look at what we haven't done fully and really accelerate those things.
Thanks. Mia, you were going to respond as well?
Yes, there's an interesting media question. So Ida Uester, I know Ida, she worked for Internews, the media organization that had to let so many people go, and she lost her job because of this whole crisis. And she says, I hear various speakers talk about autocracy and making clear statements about ridiculous science denialism in the US. In the mainstream media, one sometimes sees what appears to be a normalizing of outright ridiculous actions. And she wants to know, can we speak to journalists' dilemma of wanting to show fairness in an era where some decisions are downright absurd? So, and how is the US media credibly handling this, in our opinion? So, Ida, just like you, when people make ridiculous statements in the media that are just downright unscientific, I'm not going to give them I'm not going to even give them a chance to speak. If an anti-vaxxer talks, I'm not going to, because there needs to be fairness in media, allow, anti-vaxxer response for each, person who supports the science of vaccines. In fact, I'll probably not give the anti-vaxxer any response because I think it's just damaging. So there's not an equal power thing. But when it comes to, the US media's handling of this situation, I mean, I think they're doing pretty well. What they remind me of is, and it was the same during COVID because Trump was also for part of that president. It reminded me of the coverage that we had in South Africa during HIV denialism, where it's very much, you're almost like a fact-checking agency. Someone says something, a person in power, and your job is then to go and debunk it. And that sometimes prevents you from becoming very insightful because you spent so much time on just reporting the wrong statement and then, correcting it. It almost takes resources away from doing other stories. So in South Africa during HIV denialism, because we did so much Mbeki and Mantu debunking stories, we almost never reported on the science of HIV, because, not of HIV, of ARVs. We never reported on, like how do ARVs, for instance, how do you roll them out? Or what would be the best ways for South Africa to roll them out? We concentrate so much on, like I said, they're not poisonous because the president says so. And I wonder what Mitchell thinks about, what is happening in the US. Is there a similar sort of reporting in some media like that? He says, she says, and then we say what's the right thing? Or is there room for insightful sort of reporting? Or is the crisis just so large that, you can only do so much?
Yes and yes. It's so large, you can only do so much, and there's still room for if we don't continue to put the right information out, evidence-based science across the board, and as you all know, we have Mantu Shabalala has come back to life in the form of Robert F. Kennedy Jr. And as someone who's lived in both countries and lived through them both, it's horrifying. But we can't not take it on and do it in the exact way you're describing. It's essential.
Thank you. I do remember those days very well too, and it does feel a bit like deja vu, I think, as Mia kind of suggested, excepting it's so much bigger. You know, here it was a concern for HIV, and but with busy people like they have running their health department now, we do know it's going to affect so much more than just that. And I think Mia mentioned something about how ridiculous some of these decisions are, and some of the choices, and they simply don't make any sense. And of course, I think that's deliberate. I mean, I think that's strategic as much as it is anything else. To try to find any sense in some of these decisions would just be to waste your time, because the agenda is something completely different. And we are just dealing with irrationality, which, of course, you know, is exactly what we dealt with in the 80s, but just on a much bigger scale. So yes, I think it's ended up being a very much more positive engagement than I was expecting. I always have to prep myself for these things, because I, you know, try to bring some hope into them, because often there doesn't seem to be much. But I think a lot of positive has come from this discussion, and I hope we can take it further. But I do think we've probably used up as much of people's time as we can. I want to once again thank our panelists so very much for being prepared to share with us. You are far closer to all these issues than I am, and I wish you well. I have, apart from obvious concern for patients and for people who rely on so much support and funding, apart from all of that, I also am deeply concerned about the health workers and the community workers and the others who've been so badly affected and will continue to be. And hopefully there are ways in which we can respond to that as well. So thank you everybody again for joining us this evening, and I wish you all well, and strength to all of us in these interesting but challenging times. Thank you.
Great. Thank you so very much. Great to see you all. Have a good evening.
Thank you so much. Thanks, everyone. Bye-bye. Did Prof leave us?
I think so.
Okay.
But great to be with both of you, and him too, but great to see both of you.
Thank you.
And
You
thank
are
you.
great. I mean, you've said a lot of the things that we couldn't say. So thank you for that.
Well, I want to thank you, because I know how hard it is for so many implementers to speak out, and you are unique in that. And that's frankly way more powerful than anything I can say. I sit here on the American side, but you're actually dealing with real lives and real people. So thank you. It takes a lot of courage.
Thank you. I appreciate that. And thanks, Mia.
Oh, you're on mute, Mia. Oh, Mia, you're on mute.
Sorry. I was wanted to say you both are very, very brave to speak out. Yeah, especially you, Ntomfikile. I mean, it's a very courageous step. And I have a feeling because you've done it, others will follow. You're leading the way. Yeah.
Totally true.
Hopefully.
The only thing I was going to add was that at least you all are at whatever 6:45. You can legitimately have a glass of wine now. I have to still wait. I'm hoping to get. I hope to get out of this country soon enough. But I will be in South Africa hopefully soon, and I'll let you both know, because it'd be great to do this in person, and maybe even schedule something in a open in-person meeting. But
yes, that'll be
just great to see you both.
Thank you, Mia. Thanks, Mitchell. Hope to connect.
Thanks for helping
very
pull
soon.
together, man.
Thanks.
Cheers.
Bye-bye.